to bring the training to Indonesia. And this is where I'm hoping with IC Tech. Yesterday was a momentous day because we had Carl Storz come and sign an agreement to donate 6 laparoscopic sets to Chipto. And we hope that in a few months we will change this empty spot into a proper skills lab so that we can train all the surgeons we want to do this sort of surgery. The sort of surgery that I've done, the esophageal atresia, the pyeloplasty, the duodenal atresia, for those of you who are interested, is still not available in Singapore because they don't have the proper trainers. So it'd be nice if Indonesia can do something that Singapore can't. I'm also very glad that in the last few years, I've found 2 people who are in the audience today who spent 1 year with me. Dr. Rihanna and Dr. Iskandar. They had 1 year with me. They have come back to Chipto and they're going to be starting to work as a team to bring in laparoscopic surgery. It was Dr. Amir Taib who was very, very persuasive to ask me to ask him to join me. And I was actually very delighted that they came because I got to know Indonesians better. And I think the future for pediatric surgery in Indonesia is also laparoscopic surgery. I would like to finish by quoting a famous quote from Steve Jobs. And everybody knows Steve Jobs. If you want to know where the future is, I think the best way to predict the future is to invent it. And I hope that in the next few years, we will be able to invent laparoscopic surgery for all Indonesian children. Thank you.
Thank you, Prof. Tan. Sekarang kami memberikan kesempatan untuk teman-teman sejawat dari Unsyah, dari Unpad, dari UGM, dan dari Surabaya untuk menanyakan sesuatu apa saja kepada Prof. Tan. Silakan. Atau dari UI barangkali. Silakan.
I have question, please, Aceh.
Yes, please.
What kind?
Sorry, we cannot hear Aceh.
What kind pediatric case you can reconstruction by May I have question, please?
Yes, please. We can hear you now. Okay.
What kind pediatric case you can reconstruction by laparoscopy?
Oh, okay. I understand you want to find out what kind of cases. Yeah.
Tolong mic-nya di mute setelah dipakai untuk bertanya.
Okay, I understand the question is what kind of cases can be done laparoscopically. I estimate that 60% of all open surgery in children can be done laparoscopically. If you have appendicitis, it is very routine now. Fundoplication, cholecystectomy, splenectomy, bowel obstruction, ovarian cysts, anything that's inside the abdomen. When I was in Kuwait, I operated on a 10-year-old child with a ovarian cyst the size of a football. And in that child, I did all the mobilization. I emptied the cyst and I made a 5-centimeter incision and pull the cyst out instead of having to make a long incision. So excisional surgery, you can do all that. For congenital abnormalities, the other thing which is very good is, I think in Asia, you have a lot of children with pneumonia and parapneumonic consolidation. If they need to have a decortication, Today I would put in a chest, a thoracoscope, and have a look and do a thoracoscopic VATS decortication instead of thoracotomy. For congenital abnormalities, I'm happy to do esophageal atresia, choledochosis, malrotation, duodenal atresia, Hirschsprung's disease. So I think that as the expertise grows, you will find that your Indonesian patients will get more benefit from having the same operation without needing to have a big cut.
Yeah, thank you, Prof.
Apakah ada yang lain lagi dari Unsia? Kita harus membuka satu-satu supaya transmisinya lebih baik. Dari Unsia barangkali ada lagi yang lain sebelum kita pindah ke tempat lain. Silakan.
Kita punya satu kasus atresia osofagus dan duplikasi, dua kasus dan duplikasi kolon total.
They have a case with esophageal atresia and duplikator dari apa? Sorry. Colonic duplication.
Total duplikasi kolon dengan appendix 2 dan dia punya fistel rectovagina.
And they have two appendix with rectovaginal fistel.
Mungkin Prof bisa memberikan pendapat. Sekarang sudah kita iliostomi. Definitifnya bagaimana?
Can you give a suggestion? What should they do with this patient? With esophageal atresia and total colonic duplication.
The
two appendix.
Okay, the esophageal atresia has been repaired.
Atresia esophagus sudah diperbaikin atau belum?
Atresia esophagus tanpa fistel. Enggak, ini dua kasus yang berbeda.
Oh, sorry. This is two different cases.
Two different cases. Certainly, if the esophageal atresia has very good lungs, which is a problem, they have to have good lungs. Because when you do the operation, you have to collapse the right lung. And if the baby has got good lungs, then it is possible to do the operation totally thoracoscopically. So, that is the status. With the duplication cysts or intestinal duplication, you need to resect the segment. And if it is total colonic, you will have to resect all of that because you cannot remove the duplication by itself and spare the good side. Certainly, you would be able to do a laparoscopic mobilization of the colon and maybe take it out through a small hole. I have done laparoscopic total colectomy in Australia for ulcerative colitis, and you can do it through a small hole. So I think you can convert a very big operation, a big scar, into a small hole by using laparoscopy to mobilize the bowel.
They did ileostomy already, and what should they do?
Well, if they have to remove the rest of the colon, they can mobilize the whole colon laparoscopically.
Okay, and after that?
And after that, pull it through the ileostomy.
Oh, so it means that it's ileostomy for his whole life, this baby's whole life.
Yeah, I think if you have a duplicated colon right down to the anus, you probably have to take the whole thing out.
Okay. Bagaimana Dokter Muntadar?
Ya, mungkin nanti kita merencanakan untuk memotong septumnya semua. Apa begitu cara penanganannya?
Menurut Prof Tan tadi bahwa kita harus memotong semua kolon, artinya membuang semua kolon yang duplikasi. Setelah itu dia akan menggunakan ileostomi seumur hidup. Itu yang dikerjakan.
Atau kalau di full through ileostominya gimana?
Can we make a pull through from the ileostomy through the anus?
Yes, you can. I have done it for total colectomy for ulcerative colitis, but these patients will have problems with continence and control for quite a long time.
Oke, clear Dokter Muntadar ya, bisa. Jadi bisa dilakukan.
Oke, ya, bisa. Kalau yang tanpa fistel itu sekarang kita udah osofagostomi sama gastrostomi. Idealnya umur setahun atau umur berapa yang paling bagus untuk kita transposisi kolon atau gastric pull up?
The case with esophageal atresia, the baby with no fistula, they already did esophagostomy and then gastrostomy.
Oh.
So in your opinion, how old and when should they do the next operation, colonic transposition or whatever?
How old is the patient now?
Nah, berapa umurnya sekarang, sorry? Umurnya sekarang?
6 months.
6 months.
6 months. I think it can be done now. We will not be able to get a primary repair, but we should be able to do a gastric pull-up and bring the stomach up into the chest to anastomose to the neck.
Ya, jadi sudah mulai bisa dilakukan sekarang, Dr. Muntadar.
Oke. Thank you, Mr. Prof. Tan.
Oke,
Thank you. Terima kasih.
Barangkali kita pindah dulu ke Unpad barangkali. Ada pertanyaan? Dr. Kiki, saya lihat ada di sana. Selamat siang, Dr. Kiki.
Selamat siang, Dr. Yana. Sementara belum ada, masih mikir ini.
Oke, Surabaya barangkali ada 4 konsultan di sana. Terima kasih banyak sudah datang. Silakan Surabaya kalau ada pertanyaan.
Terima kasih Dr. Yana. Dr. Yana. Dr. Yana.
Silakan. Ya, silakan Dr. Kustio. Silakan.
Good afternoon, Professor Tan. I congratulate to you as a young professor in Indonesia, especially in University of Indonesia. Welcome.
Thank you. Thank you, Dr. Gunawan. Nice to see you again after Banjarmasin.
Thank you. First, I want to ask you about your experience. In Surabaya, I did many laparoscopic, laparoscopic and thoracoscopic. And I want to ask you, is it you have a criteria for thoracoscopic surgery? Is it especially need the respirator? Or respirator? Yes, respirator after the operation. This is a must needed after the operation.
For thoracoscopy.
Yes. In your experience.
In my experience, I think it depends on how late you get the patient. In Australia, we get the patient, say, for decortication early, and the lungs are not so bad. So it is not usual for us to ventilate them afterwards. For esophageal atresia, I ventilate them for 1 or 2 days afterwards because that is supposed to be protective of the anastomosis. The group in London, Professor Agostino Piero, they showed that if you flex the neck and you paralyze them and ventilated them, you stop the anastomosis from under tension. So I do that not because the child needs it, but just to protect the anastomosis. Because for the esophageal atresia, it is a transpleural operation. So we have to be a little bit careful.
Yes, thank you. And about hernia, diaphragmatic hernia.
Oh, diaphragmatic hernia, in the older child, I do it from the laparoscopy. In the younger child, it's easier from above. It's easier to reduce. And I'm sure, Dr. Gunawan, that you can do all these things because you've had so much experience. You know, I think when we were discussing 2 or 3 weeks ago, you were saying that you are doing the duodenal atresias and choledochosis, and it shows that these things are possible in Indonesia, and I think it's fantastic.
Thank you. Terima kasih, Dr. Yana.
Ya, ada lagi barangkali dari Surabaya?
Masih, Dr. Yana.
Silakan, Dok.
Good afternoon, Professor Tan.
Good afternoon.
I'm Miss Purwati from Surabaya. I see you make choledochoduodenostomy for the choledochal cyst. After you excise the cyst, you make choledochoduodenostomy. Why?
Yeah.
Yeah. Why don't make choledochoduodenostomy?
Okay. That is a very good question. When I first did the operation in 2003, and I presented it, I got into terrible problems, especially with the Japanese. Because all the Japanese saying you have to do Ru-on-Y. But there is a lot of evidence now. Dr. Liam in Hanoi and Dr. Alan Flake in Philadelphia have produced large series to show that the results of hepaticoduodenostomy for choledochal cysts is the same as Ru-on-Y. In Dr. Liam's series, he shows that if you do a Ru-on-Y, there is a higher incidence of malabsorption. The worry with hepaticoduodenostomy is bile reflux, but in Dr. Liam's series, his incidence of bile reflux is 7%, and it didn't require any further treatment, any serious treatment. My main concern about choledochal cysts is that in the long term, when they're 10 years old, when they're 15 years old, they start to get into trouble. They have intrahepatic stones, you have to look for cancers and all that. And if you have a Ru-on-Y and they have an intrahepatic stone, you cannot do anything. I think if you have a hepaticoduodenostomy today, by the time they're 14 or 15, it should be possible for the gastroenterologist to do an ERCP and to check intrahepatic to see that there's no malignancy. And I think that the argument now is more towards hepaticoduodenostomy.
Thank you.
Ada lagi barangkali dari Surabaya, Dr. Adria, Dr. Fendi? Oke, barangkali kita pindah dulu ke Gajah Mada barangkali. Kalau ada pertanyaan silakan.
Ya, sini.
Oh, selamat siang Dr. Mahmudi.
Selamat siang. Good afternoon, Prof. Tan.
Good afternoon.
I have question about urologic case in laparoscopic. I have one case varicocele, scrotal varicocele. How to
Varicocele.
Yeah, how to manage recommendation with laparoscopic. Example with procedure Palomo procedure. With
I do a Palomo procedure laparoscopically, but I do a different Palomo operation. If you do a non-Palomo, that means if you spare the artery, there is about a 11% incidence of recurrence. If you do a Palomo, that means you cut the artery and the veins completely. The incidence of recurrence is only 1%. But then you have a higher incidence of hydrocele. You have a high incidence of hydrocele because of interruption of lymphatic drainage. About 6 years ago, I described a lymphatic sparing Palomo, and this is quite an easy operation. When the patient is anesthetized under a GA, you have 2 mils of methylene blue. You put into the testicle just between the tunica, and you massage the testis for 5 minutes. And after that, when you do the laparoscopy, you can see the blue lymphatic vessels. And the artery and the vein is not blue. So you can cut everything else but leave the lymphatics. And we have done this now for about 8 years.
Okay. Thank you. Thank you.
Ada lagi? Ya.
Thank you.
Ada lagi dari Jogja barangkali pertanyaan lain? Silakan. Oh. Ya, Dr. Andi, selamat siang.
Okay. Good afternoon, Prof. Tan.
Good afternoon. Selamat. Yes, selamat siang, selamat petang.
Okay. I would like to ask Prof. Tan, what is your suggestion about the laparoscopic hernia. I didn't see you saw the laparoscopic hernia in children. I want to ask to you about the if we compare about the recurrences and of the hernia laparoscopic and open. What is your suggestion of this procedure? And about the scar of the operation, I think if we compare about the laparoscopic and open, I think it's the same maybe. Yeah. What is your suggestion for this case? And the
You are
second
from
question.
yeah. Carry on.
Okay, thank you. Okay.
Okay, you're from Yogyakarta, Jogja.
Okay, yeah.
Okay, I think when did I go to Jogja? About 8 years ago, and I did I did a few laparoscopic hernias in Jogja. I remember.
Okay.
I think laparoscopic hernia has a slightly higher recurrence rate, but I still do laparoscopic hernia for many reasons. The first one is that in young babies, there is a significant incidence of a hernia on the other side that doesn't show up until some months later. So if you were to do bilateral exploration for unilateral hernia, you end up doing a lot of unnecessary operations. So a diagnostic laparoscopy is very good to check if there is a hernia on the other side. The other thing too is that one of the most difficult, I have to say, not difficult, more I say challenging things to do is to learn how to do a stitch laparoscopically and how to tie a knot and how to do dissection in a small space. And both Dr. Riana and Dr. Iskandar, they did a lot of laparoscopic hernia in Kuala Lumpur because it is good practice for the trainees. They learn how to stitch, learn how to dissect. And I think because of that, I will continue to do laparoscopic hernia. There is a big multinational randomized control trial from London, Toronto and a few places that should be completed this year, comparing open versus laparoscopy, and we should know from that which one, which is better. Until then, I can't tell you which one is better.
Okay, thank you, Prof. And my second question is, how about you perform laparoscopic in enterocolitis necroticans with abdominal distension, and I think in this case there's abdominal compartment syndrome. And can you explain to us how to manage the abdominal compartment syndrome when we insert the gas with the laparoscopic? Thank you, Prof.
Oh, okay. With necrotizing enterocolitis, I am selective. If they have obviously a red, swollen, edematous abdomen, then I don't do laparoscopy because I know those patients when I go in, I will find dead gut. I do diagnostic laparoscopy for the patients who are not that sick with a distended abdomen, free gas, because if you look at necrotizing enterocolitis, there are two groups. There's a group with a lot of dead gut, and there's a group where if you do an open laparotomy, you find a little hole in a piece of bowel and the rest of it is normal. So in that group, what we call focal isolated perforation, they're usually younger children, sudden pneumoperitoneum and very little, and in that group I've been able to do a diagnostic laparoscopy, find the perforation and just do a very limited resection.
Okay, Prof. Thank you, Dr. Riana. Thank you, Prof.
Oke, barangkali kita kembali lagi ke Unpad. Ada pertanyaan dari Unpad?
Saya Dr. Riana, Dr. Diki.
Oh ya, silakan Dr. Diki, selamat siang.
Terima kasih Dr. Riana. Profesor Tan, first of all, we would like to congratulate you for inauguration of adjunct professor in Cipto,
and we also heard that you so generous to give a grant to the Jakarta to Cipto. We hope also that you so generous to give us the same one.
Firstly, thank you very much. I think yes.
I have one question for you. Laparoscopic in Bandung is just starting, and I have one experience that to do laparoscopic orthopexy in the case that the testicle is intra-abdominally. I want to know what your experience to do the laparoscopic orthopexy. Did you do one stage or two stages?
If I have an intra-abdominal testis, I do a two-stage repair. The first stage, I divide the internal spermatic artery, and the second stage, I bring it down into the scrotum. I think that it has got better results than a single stage in terms of testicular survival. You know, I was inside duduk di Australia 43 tahun. I've been back in Malaysia, in ASEAN for near 4.5 years. And I'm excited to see all the Indonesian surgeons, all Malaysians everywhere excited about laparoscopy. And I think you have a lot of clinical material, and if you do laparoscopy, it will help your situation a lot. Because if your laparoscopy can help the patient go home in 2 days rather than 1 week or 10 days, then it makes you very much more efficient, and I think it's better for the children. In terms of the grant for Cipto, it wasn't my money. It was Carl Storz. But I was very lucky to convince Carl Storz's grandson, Carl Christian Storz, to come to Indonesia for his first official visit. He came to Jakarta 20 years ago. And I think that when you bring them to a country and you can see what the country needs, then these people, I think especially the Storz family, are very generous. So what I would like to see is, let's try to make the Cipto Skill Center successful. And if they see this is good, then it will extend to every other center, hopefully in Indonesia. Because if you look at skill centers, let's example in Australia, they have skill center in every state, in Perth, in Adelaide, in Melbourne, Sydney, and all that. And Indonesia's got so many people that I'm sure that, you know, with the proper people who want to train, that will happen. But I would like to show to the Storz family that yes, they have put the money into Jakarta, and yes, it has been worthwhile because we have been able to use it to train many surgeons. So I hope that everybody will support Cipto. We will be starting to run courses hopefully by the end of this year, and you know, I would love to see everybody either in where is Unipad? In Bandung. Oh, okay. In Bandung. Okay. So, you know, I'd love to visit Bandung. Ole Bandung, you know, see your shopping. I've been to Jogja. I've been to Surabaya. I haven't been to Medan. And there are many places I think I can see in Indonesia.
Thank you.
Ada yang lain? Yes.
Thank you.
Yes. So you should go to Bandung then. We can go now after this.
Dr. Yana.
Ya, silakan Dr. Kiki.
Ya. Good afternoon, Prof. Tan. Selamat
Good
siang, Dr.
afternoon.
Yana. Dr. Yana, sebelumnya saya mau minta tolong ke Dr. Yana dulu. Kebetulan saya pengikut Soeharto, jadi nanti ditranslate ya Dr. Yana. Saya pakai bahasa Indonesia aja sekalian.
Waduh. Ya, silakan Dokter Gigi.
Iya. Kayak gini, Dok.